One thing I wanted to mention about the underlying CKD. So I do think getting a really sort of clear understanding of what a patient's baseline kidney function is actually very challenging. I deliberately sort of kept the CKD piece vague here because this patient, we might have actually benefited from having a cystatin C, for example. We know that in these patients with cancer, we're often overestimating their kidney function with creatinine. And so perhaps we should be thinking about trying to be more creative and integrating some of these cystatin C based measurements so that we can really kind of understand the baseline kidney function. And also, in terms of the AKI, it's really interesting to hear your all's perspective because yeah, we don't see these patients really until they have AKI, and so kind of understanding what leads up to the event, it's almost like a little bit of detective work for us. We're also lucky that we have access to glucarpidase, and I know that may or may not necessarily be the case at other centers, but we are pretty proactive about trying to give glucarpidase early in these patients as soon as they're sort of showing signs of kidney injury, because I do sort of anecdotally feel, even though our data didn't necessarily sort of support this, anecdotally we feel that the earlier the patients get it, the better, at least within the first 60 hours, for instance.
Yeah, Dr. Gupta, I completely agree. The saying that time is money. I always say time is kidney. We shouldn't wait for the methotrexate level to continue to rise past the limits it should, at that 48-hour mark or 72-hour mark before we say maybe it's time for glucarbidase. Early on, if we feel like we're things are looking that way, that's when we would use the mtxpk.org and sort of trend the curve and see potentially where this patient would be in 24 hours. And if it's looking like they need it, then we should give it sooner.